Hello, my name is Christina Herrin and Director of Free to Choose Medicine. Welcome to a Heartland exclusive interview with Dr. Michael Robb, otoneurologist out of Arizona, practicing for 17 years and current state chapter president of the Arizona chapter of Association of American Physicians and Surgeons. Doctor, we're so glad to have you on today.
Thank you so much, Christina. It's a pleasure to talk to you today.
Yeah, can you just give us a little bit more background on yourself and your bio here?
Well, I'm a neurologist and I have fellowship training in otoneurology, which is a medical discipline dealing with diseases and disorders of the ear and the brain. And I decided to start my practice third-party free from the start, which means no contracts were signed with Medicare, Medicaid, or insurance companies. And I've been in practice now for 17 years here in Phoenix at the Robb Otoneurology Clinic.
Great. Well, we're so glad to have you here today. And I want to start off by talking to you a little bit about the role of the Association of American Physicians and Surgeons role in suing the federal government for not allowing doctors to prescribe hydroxychloroquine to patients suffering from COVID-19, even though the drug is approved by the FDA and it's passed safety and efficacy testing, that many patients have still been denied access of off-label usage of this drug. So can you just give us a little information about where that's at?
All right. Well, we filed a complaint for declaratory and injunctive relief 2 weeks ago, and the defendants are the HHS, FDA, and BARDA, and their lead officers. Our concern was that there was unconstitutional, arbitrary, irrational, and unjustifiable bureaucratic barriers erected, which interfered with the patient-doctor relationship as regards to treating patients with COVID-19. The government put some restrictions and some discriminatory exclusions on this medicine during its emergency use authorization. So they limited the use to hospitalized patients who were not available or who could not avail of a research trial. So that limited the private physician from treating patients early within the first phase 1 or 2 of the disease process, and or prophylactically treating patients, doctors, nurses, medical workers on the front line, doctors and families. And so I believe that since they revoked the EUA in the past 48 hours, now we would like to continue our lawsuit so that the 66 million pills, or possibly more, which are in a stockpile, potentially at risk for damage or expiration, we want those medicines to be issued to physicians, pharmacists, governors, everyone who could justify a need for it and request it. And 3 months ago, we heard a lot about the term anecdotal evidence regarding observational studies that were emerging from over 9 countries. What I think is quite anecdotal is the concern that lupus and arthritis patients could not avail of their hydroxychloroquine, and thus it needed to be rationed. And we had over half a dozen pharmaceutical companies trying to increase production, and presuming they can avail of that active pharmaceutical ingredient, they should be able to meet demand. But I haven't seen any numbers and hard data regarding the autoimmune patients not obtaining their medicine. So I don't think that argument is as strong, and you can see what has happened in the past 3 months. There's been far too much restriction in that patient-doctor relationship. So it's just important for the doctor to identify a prior belief on whether this medicine will work or not. It's a fascinating, safe drug with a 70-year track record that has an interesting mechanism of action, which is a zinc ionophore. It can open up a channel and allow zinc to get into the cell, and it prevents RNA from replicating. There are numerous other mechanisms as well. And so a low dose goes a long way. And based on the current research, a doctor can update his prior beliefs and counsel the patient and make a decision accordingly. And some doctors will be convinced, in particular, those doctors who are on the front line, who are unofficial COVIDologists, if you will, and they know whether the medicine is working, and we hope that they all publish their findings. But we have data now on over 19,000 patients who have been treated with this medicine, and there's a reduction in mortality by a factor of 3. The challenge is treating patients early. I believe that this virus, pretty virulent, it can attach not only to ACE2 receptors in the lungs and the gastrointestinal tract and the brain, but also the heart. So a lot of our concerns about cardiac arrhythmia and QT elongation, I wonder how much of that was explained in part or in full by the actual disease process in the late stage.
Interesting. Well, I think you hit on some really strong points. I want to go back to what you mentioned about off-label usage, and that this drug is used for lupus and arthritis and other ailments. I think it's important for everyone out there to note that this drug is approved by the FDA. And Doctor, I'm hoping that you can maybe just touch on off-label usage, and then also just how crucial it is to allow patients and doctors to make decisions about healthcare. Healthcare is very personal. And what's happening here is really the FDA is getting in between doctor and patient relations, and that communication is something that is going to cause future issue with COVID. There is no treatment or confirmed vaccine yet, and so we're going to see many, many treatments, and that really, I think, determination needs to come from the experts, who are you guys, the doctors, and then the patients that need treatment. So again, I just wonder if you can just touch back on off-label usage and what that means here, and what that maybe means for future usage of finding a cure or treatment for COVID-19.
Well, off-label usage in day-to-day medicine may account for up to 25% of prescriptions.
Okay.
Do we have signal? Okay, I see you again. Had a brief blackout on the screen. Not sure what happened. Might have been a brownout. So there's a significant percentage of medicines that are used off-label. Neurology is a good field where we can see that. But the rheumatologists, who are experts and authors of textbooks and professors, they have a long track record of experience using hydroxychloroquine, and they believe it's safe. The concerns are valid, but they're overblown in terms of cardiac side effects in the early stages of COVID-19 treatment. However, the heart is likely more susceptible later on. So you really have to allow sufficient time with each patient visit. And that's something I have found that doctors who have decided to go third-party free, from all they've learned from the Association of American Physicians and Surgeons and their own intuition and economic and other experience, they are reporting tremendous joy and satisfaction in their practice. They have more time for patients. They can delve into more complex discussions. They can treat more than one symptom on the same day. They have time to review the research with the patient. So these patients are just making very informed decisions. So it would be wonderful if the 66 million pills could be released for use, because if that all goes to waste, that's going to be a terrible shame. The government never said that their regulations will interfere or supplant the patient-doctor relationship. But unfortunately, what they've done over the past 3 months has indeed interfered. In Arizona, for example, we cannot write a prescription for this medicine unless there's a confirmed COVID-19 diagnosis and a diagnostic code on the prescription pad. That has not been revoked. That's from our governor, unfortunately. His concern at the time was supply and safety. But now we hope that the medicine can be made available, because there's an increase in cases in Arizona. In fact, nuclear families have fallen ill and several family members have died already. The Aguirre family is an example. It would have been so wonderful to have been able to prophylactically treat the Aguirre family months ago. And there may be many other families around the world like this. So I do believe that the government has acted in a very arbitrary and irrational, unjustifiable, unconstitutional manner.
Sure. So I guess my final question here is, I have a few parts to this question. What are the next steps in the lawsuit that the association has? And do you see any future drugs or treatments that would help COVID-19 patients? And do you see the FDA acting as a barrier to getting access to those treatments?
Okay, the next step will be to have the government act, which is part of the injunctive relief. They should act to release the medicine. They have revoked the EUA, but that's not the complete set of actions that we believe are required. If it is necessary, an appeal will be undertaken at the Sixth Circuit Court of Appeals based in Cincinnati. Now, the future treatments, and some of these treatments are being researched. Keep in mind, we have 90 studies enrolling, looking at hydroxychloroquine as prophylaxis or treatment. And there are many other studies looking into convalescent plasma, monoclonal antibody, immune therapies. That has been working well, but the numbers are still small, and I think that the supply and the expense would limit wide use of that right now. But the more that patients recover, then they can contribute to this cause by blood donations. The data on remdesivir is still emerging, and specialists I've spoken to are not convinced just yet that the remdesivir is as effective or as safe as it should be. So it just remains to be seen whether that will work better in the late stage. Some of the doctors who have volunteered to go to New York during the height of the pandemic reported back that they tried everything in these patients who were in the ICU or intubated, and nothing worked. And so again, back to the importance of treating disease early. If a patient has suspected COVID, it's important to act on that. Why wait for confirmation in every single patient? That would be a delay in diagnosis or a delay in treatment. So you have a lot of clinical data emerging now from numerous scientists and physicians who are on the front line treating, where they will summarize the common presentation, which is fever and cough and dyspnea, and then lower down on the list would be pain, trouble with sense of smell and taste. So other treatments could be using some type of agent that modulates the ACE2 inhibitor in such a way that it doesn't upregulate the receptors so that there are numerous receptors empty waiting for a COVID virus to attach, but rather somehow or another blocking that receptor against the COVID virus attaching, the SARS-CoV-2. Zinc is important. In my research over the past 10 years, 60% of patients are low in vitamin D and many are low in zinc, and that's in Arizona. So using zinc in addition to the hydroxychloroquine is wise, because the function of the drug is a zinc ionophore, or a zinc channel opening drug. Now, there are other zinc ionophores out there. which are considered nutraceuticals, available at finer health food stores with a large safety profile and numerous animal and in vitro studies and some human studies in the immune and cancer domains. And those include curcumin, resveratrol, epigallocatechin gallate, derived from green tea, and quercetin. Vitamin C, given in an IV form, may be very helpful. That's certainly working nicely in Houston with Dr. Joseph Verano's hospital full-time COVID treatment efforts. He's really been on the front line with a very courageous staff of doctors, nurses, and medical students. He is using steroids, anticoagulants, vitamin C, and hydroxychloroquine, and he's treated over 100 patients.
Wow.
Successfully. Other treatments may be low-dose ionizing radiation, which was used 80 years ago and worthy of reconsideration. Also, hyperbaric oxygen therapy may also be helpful, and there are safe ways of delivering that. And there are very affordable ways of obtaining the treatment too, in a multi-place chamber run in a private setting. In a hospital setting, the hyperbaric oxygen chamber would be potentially 10 to 20 times more expensive, and they may have a lot of limitations on treating patients in an off-label manner. Ivermectin, which is a broad-spectrum anti-parasitic medicine, has viral action against COVID, and there may be great importance to prophylactically treat for thromboembolic complications with the appropriate anticoagulants. And also, just keep in mind that it's important for all of us to keep our immune systems healthy with sufficient levels of vitamin D3 that make a difference. And we're talking about, for example, 5,000 international units a day, up to 10,000 international units a day orally, as opposed to children or pediatric or adolescent doses, which are around 600 to 2,000 international units. Patients can always check their own labs. Here in Arizona, you can go to a major lab, check the labs you want, pay a very reasonable price, and then discuss it with your physician. Or, of course, the physician could order it and run it through the insurance chains. But those can be checked for under $40. And then you titrate your dose so that you're making a difference with the brand and the dose that you take as it affects your blood count in terms of what is called 25-hydroxyvitamin D. And zinc can be measured too. So it's important to take daily zinc. It is included in a multivitamin at around 15 milligrams, but there are separate zinc picolinate preparations ranging from 30 to 50 milligrams, some with 1 milligram of copper readily available, and that can be important too for basic immune health. Also, the nutraceuticals are very exciting because they're great anti-inflammatories and antioxidants, and some of them are so strong they can kill glioblastoma brain tumor cells in a test tube, or they can affect the anti-cancer drugs in a synergistic way. So in other words, enhancing the effect of the chemotherapy. There are some studies in this domain in progress, but the majority of the studies I've identified are on hydroxychloroquine and remdesivir and the vaccine is something that remains to be seen, whether it will be effective and safe. It's very difficult, I understand, to erect and develop vaccines against an RNA virus. One thing I just wanted to mention, Christina, back to the first part of your question. Imagine you're the patient, and unfortunately you didn't know that you were sick, and you visited your grandparents, and they became ill. you got better because you're young, strong, and healthy, and your immune system was better. But they declined. So they got to the hospital, and they were told, well, we have a research study ongoing. It's using hydroxychloroquine and a placebo. So if you sign this consent, then you'll be assigned randomly to one of these treatment groups, and you may get the real drug or you might get the placebo. Would you encourage your grandparents to sign that, or would you take them elsewhere so that they could just get the medicine? Or would you say, well, I don't want them to have the medicine because based on what I've heard, it's dangerous for the heart, right? So
yeah, I would definitely have to run that risk-benefit analysis, and I would do anything in my power to get my grandparents the medicine. So
do you think it would be unethical for them to only get treatment within a research study where there's a 50% chance they'd get a placebo?
Yeah, I do think that's so unfortunate. I think the fact that this drug is approved for safety and efficacy testing, and this is in terms and off-label usage of the drug, I think that risk-benefit analysis has to fall on the patient and in collaboration with the doctor and their families. I don't think the government should be making that decision, and I don't think that's part of what America believes in and the freedoms that we so prize. I don't think that falls under that category. So I think that's so unfortunate.
Well, the side effects that I've seen published so far in the studies where the data is being collected by physicians on the front line who are treating and who have identified the dosage and the treatment regimen, their cardiac side effects are between 0.1 to 2%. And the side effects for diarrhea are higher, up to 10 to 16%, and side effects for a headache and rash are around 5 to 10%. So those numbers still look encouraging to me, but the numbers are so much worse when you look at big data studies. And so Dr. Millian and others in Marseille, France have recently published a journal preproof on their meta-analysis. They looked at 20 studies involving 105,000 patients, of whom 19,270 were treated from 9 different countries, including France, China, South Korea, USA, Brazil, Iran, Saudi Arabia, and Spain. And there were statistically significant effects at reducing the duration of cough, duration of fever, clinical cure, death, viral shedding, ICU transfer, and mortality reduction by a factor of 3. They had a concern that the big data analyses, some of which were recently found to be fraudulent, and the Lancet and New England Journal of Medicine retracted these papers. They found that when analyzing all hydroxychloroquine studies, there is a significant difference between private versus big data, or versus the physician who's treating the patient and disclosing without conflicts of interest all of their treatment regimen, versus big data papers where there is at least one conflict of interest amongst the authors and electronic health record mechanisms of massive data grabbing and accumulation, and that's suspicious. So keep your eyes open for potentially up to 90 more studies on this topic, but I just hope that we can start treating patients in the outpatient setting now without further delay, without restrictions. Most states, with the exclusion of 4 states, have erected these hydroxychloroquine rationing limitations, which are putting doctors' professions in jeopardy because the medical boards are falling into this trap, and they're threatening to discipline doctors who may be using the drug. So those are my thoughts as of right now. I am constantly updating my beliefs to reach a posterior probability of treatment success using this medicine in certain cohorts. I'm saddened that it didn't work so well in the very sick patients in the hospital where we really needed something to work that was readily available and affordable and safe. But in the outpatient setting or in other settings where doctors are treating early, I'm very encouraged. I remain optimistic, and my posterior probability is higher than a flip of a coin at this point for that cohort.
Well, Dr. Robb, thank you so much for your insight and for taking time to talk with us today. Do you have any final words on the subject that you'd like to mention to our listeners?
Well, I think that patients are much smarter nowadays due to the digital domain, and they're coming in with research and good questions, and they should not be dismissed or talked down to. The visit has to be of sufficient length and detail, with empathy and compassion and scientific-based evidence as well. And one way you're going to get that is if you go outside the traditional third-party model and find a doctor who can treat you privately. Some things are just worth paying privately for. This may be one of them.
Well, thank you so much for that.
Thank you, Christina, for this unique opportunity to talk to you at the Heartland. Appreciate it very much.
Thanks for watching this video. Please subscribe to our channel and consider donating to the Heartland Institute to support more vibrant free markets, greater individual liberties, and more videos like this one.